This is Emergency Medicine Cases EM Quick Hits Podcast, and I'm your host, Dr. Anton Hellman. EM Cases is brought to you by STEMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for general information and educational purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. Unless stated otherwise, the opinions expressed by the hosts or guests are made in their individual capacity, not on behalf of the Institute nor Medicine Cases. First, a word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring a fair distribution of shifts while integrating circadian-friendly rhythm recovery time into its methodology. Less sleep deprivation means I can be a better EM doc on shift and still have energy for life outside the hospital. Check out metricade.com/EM cases to make your schedule fair and improve your sleep. This episode is brought to you by Easy Resus, the resuscitation assistant. This amazing app has drug dosing, equipment size calculation, treatment algorithms, all in under 3 clicks. Rapid access to life-saving critical info in a user-friendly interface. Try the app for free with the promo code EMCases or visit easyresus.com/EM cases. That's easyresus.com/EMCASES. When it comes to transfusions and trauma patients, there's red cells, there's massive hemorrhage protocols with red cells, there's platelets and plasma with 1:1:1 ratios of component therapy and 1:1:2 ratios, and then there's whole blood. Now, it kind of makes intuitive sense to me to simply replace blood with blood, but of course, it's not so simple. Now, thankfully, there has been quite robust literature on whole blood transfusion lately. So as part of our Best of ISEM series, that's the best of the International Conference of EM, I asked our go-to EM cases trauma expert, Andrew Petrosoniak, who just happens to be chairing the trauma section of the conference, good choice ISEM, to send me some speakers that he thought would be great for our EM cases listeners. So, to help us learn about everything we need to know about whole blood transfusion and trauma, it's my pleasure to introduce Dr. Zafar Kasim, Associate Professor of Clinical EM and Critical Care Medicine at the University of Pennsylvania at the Perelman School of Medicine. He's published on pre-hospital transfusion, and he's giving a talk on whole blood at ISEM. Welcome to EM Cases, Dr. Kasim.
Thank you so much for having me. Appreciate it.
All right, before we get into the evidence for whole blood transfusions, let's talk a little bit about what trauma hospitals are doing currently when it comes to transfusions. What is the current transfusion pattern in most hospitals in North America, in Europe, and Australia? Dr. Kasim?
Most centers, I would say, are still utilizing early use of component therapies, meaning individualized PRBCs, plasma, and platelets in an attempt to achieve 1:1:1 ratio of resuscitation for these critically bleeding patients. And that's based on the study that Holcomb had put out several years ago now that really emphasized that it's probably better to try and restore the amount of product that's being lost while you're bleeding when you're trying to resuscitate these patients. So I would say still practice has favored the use of component therapies, but now over the last 5-6 years, we've seen some larger centers, higher volume centers, I think, move to implementing whole blood early in the resuscitation process.
All right, so just to be clear there, in the US, there is whole blood being used currently. In Canada, I understand it's not being used currently. And in Europe, they're also using component therapy, not whole blood quite yet. But that's partly why this is kind of all exciting. Let's talk a little bit about the rationale and what whole blood is actually, because of course, it's not just blood. First, Dr. Petrosoniak, what is whole blood? And why would we consider whole blood instead of component therapy that we've been doing in Canada?
I think what we're talking about here today is low titer O whole blood. We're talking about cold stored whole blood where you'd have as low or as little A and B antigens as possible. And so the benefits that we start to think about, just the simplicity, I think of what I am doing in the trauma bay, trying to organize ratios, trying to administer different products, figuring out where we're at, thawing different products. This is, a logistical challenge. And when we talk to folks who are using MHPs on a regular basis, a lot of the logistics and the challenges that people experience are around how they're dealing with ratios and how they're dealing with different component therapies. So certainly it seems to me that there'd be a lot of logistical simplicity that exists with whole blood. It certainly seems a lot easier, particularly in resource constrained environments, to be using.
All right, fantastic. So yeah, some of the kind of more obvious advantages would be logistical. It's just simpler to give. You could probably give it faster. There's some other rationale that I'd like to talk about a bit more. There's, universal compatibility. You don't have to balance the component ratios because it's already balanced. Dr. Kasim, could you elaborate a bit on the sort of rationale for whole blood, maybe a bit about the history of how it came to be used and why we would prefer it over component therapy?
Yeah, sure. And actually, the history spans almost a century, to be honest. I mean, that whole blood was utilized in all the major wars, World War I, World War II, Korean War, Vietnam War. I think the only real victor in war is medicine in many ways, because we learn a lot in how to manage critically injured patients. And that was the way things were moving as people moved from using component therapies to utilizing warm, fresh whole blood, and people literally lining up and donating their blood, and that was being transfused into an injured person. And Dr. Shackelford was one of the earliest ones to kind of really look at what the benefit of this might be. And it's, if nothing else, I would look at her index paper and look at the Kaplan-Meier curve of survival between patients who got warm, fresh whole blood to component therapy. And there's an early and sustained separation of the survival curve in the whole blood group that really sparked a lot of interest across the military. And that really changed practice, that, the utilization of whole blood seemed to be a much better way to manage the early resuscitation of these trauma patients. And so on the back of the positive military literature, clearly we still had a problem with potentially preventable death from hemorrhage in civilian practice. And so there was a question about whether we could translate this into civilian use. Now, the product that's used in civilian practice is different. So it's the cold stored, low titer O whole blood. And that's essentially O positive, low titer, as we mentioned, just to minimize the possibility of reactions. But it's a different product than what was being given in the military. What I would say is beneficial over and above the component therapies, and this may be as a result of the mechanisms required to separate different blood components, is that when you compare a unit of whole blood to the equivalent of red cell, plasma, and platelet components, you actually get a higher hematocrit, higher platelet count, at least early on, and a higher amount of clotting factors in the whole blood unit as compared to the equivalent that you would give as component therapy. And that might be one of the reasons why the benefits of whole blood outweigh just the logistics. It's that you're giving a physiologically better product to your bleeding patient who's essentially losing a lot of these substances. So over the last decade, we've even seen an evolution in how the cold stored whole blood is being developed. There's better kind of development of each unit. There's better storage with the citrate that's used as a preservative. And so the shelf life has increased. So we're seeing better ways to maintain kind of the amount of platelet function and clotting function in the units early on than we had even 10 years ago. So there has been an evolution even in civilian practice of the blood that we're using now.
All right, great. So just to review there, it sounds like whole blood is physiologically better than component therapy, that it's logistically simpler. And my understanding as well is that there's actually less transfusion-related reactions with whole blood than there is with component therapy. Is that correct?
Yeah, there's decades of data that have looked at whole blood complications, right? So from all the military data, there was very few transfusion-related complications. And similarly, there's been very few reported in civilian centers now that are using whole blood. Just from our own practice, we've had a whole blood program up for over 5 years now at our center, and we've had maybe less than a handful of issues, some related to kind of more volume-associated problems in people who had coexisting disease, but no real concern about a transfusion-related reaction or in terms of incompatibility or any major problem like trolley or anything like that.
So it sounds like there's many advantages to whole blood over component therapy. That brings up the question, Dr. Petrosoniak, why aren't we using it in Canada? And in Europe, I understand as well, it's not being used. So why is this only in the States? If it sounds like it's generally better than component therapy, why aren't we using it?
Yeah, it's a great question. I think there's probably, you can look at the link to medicine and the military that's, I think, much stronger in the US and certainly drives a lot of the innovation, as Zaf already alluded to. It isn't without some risks. Like anything, the data to support whole blood as superior to component therapy, I would say is, well, not strong. It's robust in that there are multiple studies, study after study, very few. In fact, I think maybe only one I can think of that shows component therapy to be better when you look at it in a correlation kind of manner, in an observational manner. But the lack of RCT evidence is clear, so to say that it is definitively better, I think would be maybe an overstatement. If I had money to put down, I would bet that the RCTs that are being done will show probably a favor towards whole blood, depending on the outcome they're looking at. But I think that part, rightly so, I guess I would stand in a position where I'd say, I think we would want to have RCT level data before we move to, widespread adoption when, this does change the game in terms of costs and availability and just the way that our resources are just not the same as the US environment, and being able to scale up like they have, it's just different than in the Canadian environment. So I think that part, those who are staunch advocates for whole blood should be available everywhere, would look to observational studies to support its use. Those who would say, maybe we should put the brakes on it and let's get some studies, would say there's a lack of randomized control data that suggests that. And, I guess you can decide where you want to fit in there and how you see how you see evidence and need to move. The final piece that comes up, and is discussed is where does whole blood fit in women of childbearing age? The majority of the available products are O positive. And so as a result, if you roll out a whole blood program, you are in theory giving women of childbearing age, not knowing their, in a trauma environment, you won't necessarily know their Rh status, and you run the risk of administering O positive blood if they're O negative, which puts the patient at risk subsequently, puts the, subsequent pregnancies at risk for hemolytic disease of the newborn. And so that has started to be looked at in terms of quantifying that risk. And most of this is based on estimates. And I think you'll look and see that those who are, believers in the value of whole blood for all of the reasons that we've kind of described would look at the data and say the risks are overstated. They have gone out and asked for, qualitative surveys of women who, how do you see this risk? Would you be okay with this risk? It seems to favor, administration and use of blood for women of childbearing age, regardless of the Rh status. That said, my position would be, I bet you people's position changes in the moment if their child, unfortunately, happens to be the one that has hemolytic disease of the newborn. In the moment, it's easy to sort of say 99% chance of nothing bad happening, or maybe, 99.99% chance. But if you're that 1 in 100, 1 in 1,000, 1 in 10,000, you may have a different position at some point. So I think, anytime you're asking people as hypotheticals to justify a position, you just have to understand there's some limitations in the human mind in terms of how we see these predictions. But overall, time and time again, that the data seems to support, and the estimates seem to say that risk is low. But I would say it's not zero, and to some degree, ultimately you have to make a decision. And I guess staff might be able to speak to how they thought about it at their center. I think it's something that needs to be spoken about and would be an institutional level decision or a programmatic or an organizational level decision rather than you can't put that on the clinicians in the moment.
Okay. Yeah, very balanced answer there. Thank you, Dr. Petrosoniak. It's not so simple. The data so far suggests that whole blood might be better, but there's no great, robust RCTs quite yet. Logistically, it seems much simpler. Overall, there's probably less complications and side effects, but there's this key issue of Rh status, Rh negative women and hemolytic disease of the newborn that we don't quite know exactly what to do with yet. I want to talk a little bit more about logistics. So it seems that some of the advantages of using whole blood over component therapy are related to easier logistics, but as always, there's logistic challenges with everything we do in emergency medicine. What are some of the logistical challenges and solutions of using whole blood? In particular, Dr. Kasim, if you could comment on how whole blood is acquired, how it's stored, and how we deal with the waste.
Yeah, and I think that hits on one of the biggest logistical challenges of it. Overall, especially since COVID, we've seen a decrease in our blood availability nationwide, and I'm sure Canada had some similar challenges as well. But because donors weren't there, and so they weren't showing up to donate, and so anybody listening to this podcast, I'd really encourage to become a blood donor if you can. But that's the biggest challenge. You have to have people donating blood to be able to get the whole blood. And so our availability has varied over time depending on what our blood supplier has been able to provide. So that would be one logistical challenge. But the whole blood, once it's acquired, then undergoes the usual checks as per any other blood unit. And then the question is about how long you keep that unit without it going to waste. Now, there's challenges with storing this for long. We know that the longer you store the whole blood unit, the lower the platelet function becomes. So fresher units are physiologically better than older units. And of course, we don't want to be in a position where we're wasting blood. So different places have looked at that in different ways. So either groups of hospitals have utilized kind of a rotation system where they will send the newer unit out to one of the smaller hospitals that has less likelihood that they'll transfuse. And after a certain number of days, the unit gets rotated back to, say, the trauma center where no doubt it will be used before it expires. So that's one way to do it. The other way to do it is if you're in a single hospital system, you can keep your unit in the fridge for, say, half the time that it is allowed to do. And if it's not being used, then it goes back to the blood bank where it can actually be broken down into components. And so you can limit waste in that way as well. But whatever way you decide, I think you have to look at all these. It is a finite resource that's becoming really challenging to acquire in the current setup, just with all these post-COVID in particular changes in blood transfusion, et cetera. And so those things need to be thought about as well to kind of minimize the waste and maximize the use of this scarce commodity.
All right, so that's a little bit about the logistics of storage, et cetera, and wastage. I want to talk about when you'd actually pull the trigger to use whole blood. We've talked about triggers for massive hemorrhage protocols extensively with Dr. Petrosoniak on EM cases before, and I'll refer people to our massive hemorrhage protocols episode for that. When it comes to whole blood, Dr. Kasim, what should be the trigger to call for whole blood? And what would the evidence suggest the trigger should be?
Yeah, so our protocol, I'll give you as an example. So we will administer whole blood to patients who arrive who are alive. So if you're arrested pre-hospital, then you're not eligible to receive whole blood. So if you're alive and you have, we use the ABC score for our trigger. So if you score 2 or more based on either penetrating mechanism, hypotension, positive fast, profound tachycardia, then you're eligible to get up to 4 units units of whole blood in the resuscitation bay before moving to component therapy. So that's our trigger, that you have to have a severe injury, have signs of life, and trigger an ABC score of 2 or more. And if you don't, then you'll get component therapy as a default.
Okay, that sounds nice and simple. I'm sure Dr. Petrosoniak's kind of chomping at the bit here because he's given talks extensively and thought about this a lot, of triggers of massive hemorrhage protocols. Dr. Petrosoniak, any comments or concerns about the trigger for whole blood? That, again, is you have a patient who arrives alive with a severe injury, an ABC score of 2 or more, and they're eligible to get 4 units of whole blood. What's your opinion?
We know that our ability to predict who needs sort of moderate to large volumes of blood and or sort of a full court press of MHP is quite poor generally. It's just hard to do. We're always surprised with the odd patient that stabilizes after just a couple of units, or the one that looks very well when they come in or reasonably well, and then suddenly they bleed far more than you expect. And so I think ABC score, whatever you're using, some scoring metric, some degree of objectivity, and then some degree of a clinician gestalt probably makes the most sense.
Yeah, I've heard of other protocols as well that you first give 2 units of red cells, and then if the patient continues to be not doing well, that's when you start your whole blood. So it sounds like there are different protocols in the US, and we should look forward to some more studies on exactly which protocol makes the most sense.
I mean, personally, I like the idea of an initial upfront whole blood unit. That to me makes more sense. But I guess, somebody using 2 units of packed cells might be looking at it from more of a resource management perspective, not to deploy whole blood unnecessarily. But, because of our poor predictive abilities at the bedside, a unit or 2, I mean, it sounds like Zaf's using up to 4, but a unit, as a bit of a speed bump of whether I'm going to activate my MHP or not. Do I give 1, and then if I need more, okay, then I'm going to activate MHP. If I don't, then I might just pause and maybe be a bit more nuanced with the resuscitation.
Yeah, and there is some again, kind of with the challenges of the quality of the studies, but certainly observational studies that say that the earlier the whole blood is administered, it seems to do, at least in terms of early morbidity or mortality, it makes a difference. So I think, yeah, certainly utilizing whole blood up front is probably the way to go.
Yeah, I think Anton, I think what Zaf's probably alluding to is a study that was just published recently looking at even every minute delay to whole blood, recognizing the limitations of the trial, but every minute delay with an inflection point around 14 minutes. So being as early as possible, if you decide, hey, this is the path we're going to be taking, just like we've seen with component therapy, earlier blood resuscitation, blood product resuscitation does seem to be beneficial by and large, which, intuitively, it's nice when what the studies show us seem to make sense with what we want to believe. Patients who are bleeding do better when you give them blood faster and earlier. Fortunately, it seems like the physiology aligns with the way that we expect things to move.
Mm-hmm. All right, so we've talked about when to trigger starting whole blood. What about when to stop whole blood? So you've given, let's say, 4 units, Dr. Kasim. Do you keep on going? When do you stop? Do you then change to component therapy? How does that work?
Yeah, and I think that's the next question that we need to answer. And luckily, there is a trial that's currently underway that's kind of looking at that right now. It's called the TROOP trial. It's a randomized controlled trial to say whether early, and by early, I mean up until the point that the patient has achieved initial hemorrhage control, whether utilizing just whole blood or transitioning to component therapy is the better way to go right now. I think really from a practical perspective, we limit our use to 4 units up front and then move to component therapy. But we still don't have the answer about whether that's the right thing to do or not. It's from a resource perspective, it makes sense, but from a patient perspective, watch this space. So hopefully the TROOP trial, which is a multi-center trial, will provide some interesting answers for that.
All right, great. I want to talk a little bit more about the evidence. You've touched on some of the studies. I just want to tell people a little bit about the guidelines first. So the East guidelines, for example, when it comes to whole blood, they conclude that, and I'll just quote this directly, we conditionally recommend whole blood resuscitation in adult civilian trauma patients receiving blood transfusions, recognizing that data are limited for certain populations, including women of childbearing age, and therefore this guideline may not apply to these populations. There was a recent meta-analysis out of the Journal of Trauma and Acute Care Surgery. Their conclusion on whole blood was civilian trauma patients with acute traumatic hemorrhage treated with whole blood plus minus component therapy as compared to component therapy had lower odds of early and 24-hour mortality. And in addition, whole blood transfusion resulted in higher platelet RBC and plasma RBC ratios. And there was a recent landmark study out of JAMA Surgery in the US and Canada that concluded that whole blood massive transfusion protocols were associated with improved survival in trauma patients presenting with severe hemorrhage, with a survival benefit found early after transfusion. When I read these conclusions of all these meta-analyses and the guidelines, my first reaction to the papers are, it's nice that there's a 24-hour mortality rate improvement with whole blood over component therapy, but is that really what we care about? I mean, what I'd like to know is the long-term outcome of these patients, like the patient-centered outcomes, at 30 days or a year or what have you. Are these patients doing any better? What's your take on the actual evidence for whole blood transfusions?
Yeah, I think it could certainly be better. Most of it is observational or retrospective in nature. There was an early small randomized controlled trial that Brian Cotton had done about a decade ago, but was using a different product than what we have available to us now. But again, really didn't show a long-term survival benefit of whole blood as compared to component therapy. Most of the observational studies and retrospective studies do seem to support the early survival, though. But I agree with you. I think, what we really want to see is, what happens to these patients at the end of their hospital course. How are they different from the people who've gotten component therapy or traditional resuscitation, so to speak, in the past. And we don't have that answer just yet. And I think the other question that's not been answered, and probably because a lot of these patients have been excluded, is, of course, the big challenge with trauma is the concomitant traumatic brain injury. And so, does the whole blood actually benefit those patients? Say you have a torso injury and a traumatic brain injury, or even an isolated traumatic brain injury who's hypotensive for whatever reason. The animal data seems to support the use of plasma for these patients as opposed to any other components. So giving whole blood to a patient with a concomitant traumatic brain injury, is that actually good? So those patients survive 24 hours, but in the long term, has it done them any good in terms of their neurologic recovery? And so these are all questions that are really important to look at before I think we can make blanket statements about utilizing it, and perhaps is a reason why places like Canada have perhaps rightfully put a little bit of a pause on widespread implementation.
I'm not sure that we necessarily will see long-term data, at least in the near term, because it takes a while to get that data. So we're left with making a decision with the best available data we have. I certainly favor the Canadian approach in this, being a bit more cautious with this, being looking at recognizing that, starting to implement something based on observational studies is fraught with problems. That said, we benefit from the US doing this work and implementing, and so then we can kind of sit back. So somebody does have to take the lead, I think, practically, and start doing this. And there is enough, it doesn't seem like we're seeing big safety red flags that are coming out of that, and it's done with good intent, and it's being monitored and being studied, and so we're, as Canadians, we're grateful for that work. I think that there's enough data now that I don't think it's inappropriate, unreasonable to be pursuing a whole blood program at an institution at all. But the strength of the recommendations, I think, are appropriate given the current data.
Well said. So just to sort of summarize some things we talked about, whole blood probably does improve 24-hour mortality. However, this is not based on any big RCT data. We still need more data. And in particular, we should be looking at penetrating versus blunt trauma. We should probably be looking at head injured versus not head injured trauma and figure out which subgroups whole blood would be best for. It theoretically, physiologically seems better. It is most likely logistically much simpler. There is probably a reduction in transfusion reactions. The safety data so far looks very good, but there is still the issue of the childbearing woman who may be Rh negative. And so these are some of the things I think we should keep our ears and eyes out for over the next few months and years. Hopefully there will be some further data that supports one way or another. Thank you so much, gentlemen, for your insights into whole blood. Thank you very much.
Thank you.
Thanks, Anton. It's always a pleasure.
And now for the best of University of Toronto emergency medicine.
Do you use calcium channel blockers to manage atrial fibrillation? This might be a little bit niche because there are so many other options, from rhythm control to beta blockers to whatever, but calcium channel blockers probably are the most effective rate control agent that we have available to us, and so they are widely used, but some people get concerned about side effects, especially hypotension. Now, one option if a patient does become hypotensive is to give some calcium, because calcium appears to have more of an effect on the peripheral vasculature than it does on the heart, and so you can reverse some of that hypotension. But we now have an RCT asking, why not just give that calcium up front? Why not try to prevent the hypotension? So this paper is by author Az, that's just AZ, in the American Journal of Emergency Medicine, February 2025. It's a single-center RCT that enrolls adults with atrial fibrillation and a heart rate over 120. Everybody was given an IV Diltiazem dose of 0.25 milligrams per kilogram as a push dose over 2 minutes. And that's one issue with this trial that we'll come back to in a minute. There are 3 groups: calcium chloride, either at 90 milligrams IV, 180 milligrams IV, or placebo. Now, the math here is a little bit confusing because they are dosing an elemental calcium chloride. 1 amp of calcium chloride is 1 gram, but that's only 273 milligrams of elemental calcium. So roughly speaking, we're talking about either 1/3 or 2/3 of an amp of calcium chloride, which is about equivalent to 1 or 2 grams of calcium gluconate, so basically normal-ish doses. They measured blood pressure after that at 5, 10, and 15 minutes. The stats are a little bit weird here, but essentially by 15 minutes, there was a statistical decrease in blood pressure in both the placebo group and the 90 milligram group, but there was no decrease in blood pressure in the 100 milligram calcium chloride group. So they conclude that calcium chloride works for prophylaxis against hypotension. But I think you have to dig a little deeper than that. First, there's the ever-important difference between clinical and statistical significance. The mean systolic blood pressure never fell below 115 in any group at any time, and there were no differences in adverse events. And although they don't specifically define hypotension, there was also no statistical difference in the rate of hypotension between the 3 groups. So I don't think the blood pressure differences that they measure seem to matter at all. And I think that makes sense because although changes in blood pressure happen a lot when you use Diltiazem, we almost never see clinically important hypotension. And that brings me to point number 2. They were really aggressive with Diltiazem here. They gave that 0.25 milligram per kilogram bolus over just 2 minutes. So for the average adult, that means pushing about 20 milligrams of Diltiazem. I don't think there's a need to be that aggressive. I usually start with lower doses than that, or if I'm going to give the 0.25 milligram per kilogram dose, I give it over a much longer time frame. You drip that 20 milligrams in over 15 or 20 minutes, and I essentially never see clinically significant hypotension in my practice. So I wonder whether there would have been any differences between the groups if they had just used a more reasonable or slower dose of Diltiazem. Finally, I'm not sure why they chose calcium chloride, but it's sort of a big deal. We usually reserve calcium chloride for patients with central access because it is a caustic agent and it can cause some significant problems if extravasated. And they don't mention extravasation in this paper, and they don't talk about any related harms. But it would only take a single case of severe necrosis after extravasation to negate any of the value seen here, especially because I'm not sure that we're seeing real value. And this trial is definitely not powered just for those rare but important outcomes. So overall, I think this is a great trial, but I don't think it demonstrates a patient-important benefit. I definitely will not be using calcium pretreatment routinely, but clinical judgment always applies in medicine. If I have a high-risk patient starting with a borderline blood pressure, absolutely I could see myself giving some calcium up front. Although I would definitely use the equivalent dose of calcium gluconate, like 2 grams, rather than calcium chloride. But for the vast majority of patients, I say just go a little bit slower with your diltiazem, and you will notice that almost all hypotension is clinically irrelevant. And so for the vast majority of patients, I will just wait, and I can add that calcium later if I need to, rather than exposing every single patient to it.
That, of course, was our go-to EBM guru, Justin Morgenstern. Often Dr. Morgenstern's viewpoint is quite controversial. I don't exactly agree with everything he says, but on this one, I totally agree. Start low, go slow, and if I'm going to use calcium for this, it's going to be in the form of calcium gluconate in the higher risk patients only. Do you dread doing your clinical notes every shift? Do you feel like you can never get ahead of charting? If you're shaking your head yes, keep listening. Freed is an AI scribe that listens, transcribes, and writes medical documentation for you. Notes are written in your style and ready the moment the patient encounter is over. Just imagine leaving work at the same time as your last patient. Freed is HIPAA compliant, secure, and takes less than 30 seconds to learn. Artificial intelligence can't replace you, but it can do the administrative work that no human should be subjected to. All the magic happens in just a few clicks so that you can spend less energy on charting and more time on doing what you do best. Freed learns your style over time, just like a human scribe, and it'll never quit on you. More than 6,000 of your clinician colleagues already use Freed AI. Get back to spending your clinical time caring for patients and let Freed AI do the rest. Head over to getfreed.ai and use the code EMC50 to receive $50 off your first month with Freed. That's getfreed.ai with the code EMC50. Next up, we have Dr. Rraj. She's an EM-trained ICU fellow in Vancouver who completed a POCUS fellowship in London, Ontario with Ross Prager, who kindly recommended her to me. Thank you, Ross. Here's Dr. Rraj on dynamic left ventricular outflow tract obstruction. Now, if you're like me, maybe you've heard of dynamic LVTO, but you don't really know exactly what it is, how exactly to identify it, and what exactly to do with it once you have identified it. So here's Dr. Rraj to enlighten us.
You're working an acute ED shift and you've just intubated and resuscitated a 52-year-old male with toxic shock syndrome. Despite 4 liters of IV fluids, antibiotics, steroids, and increasing doses of norepinephrine, he remains in shock. You had vasopressin and epinephrine infusions, and your bedside ultrasound shows hyperdynamic LV systolic function. There are no signs of tamponade, RV failure, or pneumothorax. However, when you reassess him, he's still tachycardic, cold, and mottled. What is going on with your patient? Dynamic left ventricular outflow tract obstruction, or dynamic LVOTO for short, is a diagnosis that we, as emergency physicians, cannot miss. Think about it in every patient with refractory shock, and when our patients are getting worse rather than better with our usual treatments for shock. Its management steps are relatively straightforward and based on principles that we're all familiar with. What is dynamic LVOTO? It is defined as an obstruction to the normal outflow of blood from the LV. This phenomenon occurs when anatomic and physiologic risk factors coincide with certain loading conditions. Now, what do I mean by that? A brief discussion on its pathophysiology will hopefully shed some light on this. The left ventricular outflow tract, aka the LVOT, sits right before the aortic valve. It's the last area that blood travels through before it leaves the heart. Blood flows at a certain speed through the LVOT. Think of the water flowing through your garden hose at a normal speed. When you pinch your hose, the water in it speeds up. Similarly, when the LVOT narrows, blood accelerates through it. As blood accelerates, it creates a negative pressure system similar to a vacuum. This vacuum sucks in the mitral valve into the LVOT during systole. That's not normal. This phenomenon is referred to as systolic anterior motion of the mitral valve, aka SAM. SAM blocks the LVOT and prevents blood from leaving the LV. This results in profound obstructive shock and a spiral into death. What are some ways that we can recognize dynamic LVOTO? The most important step is to think about the diagnosis, particularly when we have a sick tachycardic patient who worsens with escalating doses of inotropes and vasopressors. POCUS is incredibly helpful here and should be used to look for anatomic conditions that cause narrowing of the LVOT. Common ones include hypertrophic cardiomyopathy, or HOCM for short, left ventricular hypertrophy, and a sigmoid septum. However, some patients may not have any anatomic risk factors. You may just see a hyperdynamic LVO POCUS, and this is a clue to physiologic substrates that cause dynamic LVOTO. Now this is important. Anything that decreases your LV preload, decreases your LV afterload, or increases the LV contractility can trigger this phenomenon. These are conditions that we're all familiar with. Hypovolemia, sepsis, anaphylaxis, and the use of inotropes are common ones. Significant tachycardia also worsens dynamic LVOTO as it prevents adequate LV filling during diastole. To really cinch the diagnosis, we need to use certain Doppler ultrasound techniques. But don't fret if this is something you're not comfortable with. This is when I would phone a friend, whether that be another EP with advanced ultrasound skills or my cardiology or ICU colleagues. In the meantime, we can always start treatment for this phenomenon. So how do we treat it? I've broken it down into 5 simple management steps. Step 1. Treat the underlying cause. We're good at this. If the patient is bleeding, give them blood and activate massive transfusion protocol if you have to. If they're septic, antibiotics, steroids, and source control is the way to go. Step 2. Increase the LV preload. IV fluids and pure vasoconstrictors such as phenylephrine and vasopressin are your go-to agents to do this. Step 3. Increase the LV afterload. Stop any afterload reducing medications such as nitrates and hydralazine. Again, phenylephrine and vasopressin are the ideal vasopressors, as they not only increase your LV preload, but increase your LV afterload as well. Many of us tend to use norepinephrine as our first-line agent for shock, but it causes tachycardia, so pay close attention to the heart rate if you do choose to use it. Step 4. Decrease the LV contractility. The most important thing we can do here is stop any inotropes that may have been started, such as epinephrine, dobutamine, or milrinone. Step 5. Decrease the heart rate. Now I get it. It's scary to decrease the heart rate in someone with profound shock, but remember that tachycardia worsens dynamic LVOTO. My approach is to first complete the other 4 management steps in this algorithm. If my patient isn't better and is still in dense shock, then I would use a short-acting beta blocker like esmolol and call a friend while doing so. I hope this podcast has shined a light on the phenomenon of dynamic LVOTO. Remember, thinking about the diagnosis is the most important step we can take when we have a sick patient in front of us who just isn't getting better despite our best efforts. For a more detailed talk, check out my video on this topic on my YouTube channel, Hemodynamic Ultrasound. Thank you for listening, everyone.
Thanks so much, Dr. Rraj. Now, not all of us have done a thoracotomy. I certainly have not. And my excuse is that I don't work at a trauma center, and just a 15-minute ride up the road is Canada's biggest trauma center where EMS takes all the big traumas in our catchment area. But that's not a very good excuse because every now and again we receive a drop-off big trauma, and so we really all should train for this high acuity, low occurrence halo procedure. Anon Swaminathan, otherwise known as Swami, is now going to share some pearls of wisdom when it comes to resuscitative thoracotomy.
Resuscitative thoracotomies are a relatively uncommon procedure in the emergency department. Although this depends a little bit on where you work, when they do happen, we have to really reflect on the case and think about the things that we can improve for the next time. Our team recently took care of a patient who moved down the pathway and ended up with a resuscitative thoracotomy. A lot of great take-home points, starting with considering who we should do a thoracotomy in. Blunt trauma patients with arrest have a vanishingly low survival rate, and resuscitative thoracotomy probably doesn't play a big role here. I would only really consider doing a resuscitative thoracotomy in a blunt trauma arrest if the patient lost their vitals in front of me, in the department. Penetrating trauma, on the other hand, has a much higher survival rate or a much higher chance for survival. And what we're looking for is that the patient had to have vital signs at some point. That might have been in the field, but there should be a short time from loss of vitals to doing that thoracotomy. There's some great data out of LA County, a place where they probably do more resuscitative thoracotomies than any other place in the US. And that data showed that there were no good outcomes for patients who didn't have a pericardial effusion or cardiac activity on FAST exam. Those might be some good decision points. You can quickly throw down a probe. If you don't see those things, you might want to just stop and not do that thoracotomy. If you've decided to go ahead with a thoracotomy, it's important to do it immediately. Don't delay. And one of the places where we see delay is when people are providing closed chest compressions. There is no role for closed chest compressions in a patient with a traumatic arrest. There's only a handful of things that we can fix. Things like tamponade, tension pneumothorax, exsanguination, and none of those are going to improve with closed chest compressions. If we think about things like tamponade, tension pneumothorax, that's obstructive shock that caused that arrest. Closed chest compressions aren't going to help, and they can impede the procedures that need to be done. So once you decide you're going to open the chest, just go ahead and open it. Don't provide closed chest compressions. Don't let that cause any delay. The key in a successful resuscitative thoracotomy is anticipating what might happen. So there are some things that we can do before we open the chest, and while we're doing that, that can improve our outcomes. Number one is positioning. We want the patient to the far left of the bed and get that left arm up and behind the head to get it out of the way. This gives us the largest access to the left side of the chest. It's going to make it easier for us to place our rib spreader and to crank that rib spreader open. Massive transfusion is critical in these circumstances. Unless the patient's cardiac arrest was due to a tension pneumothorax, these patients are going to need a ton of volume in the form of blood. So activate your massive transfusion early, prime your level 1, make sure you have calcium ready, and give tranexamic acid. While we're opening the chest, we want to anticipate the injuries that we might run into, specifically cardiac injuries. That means making sure that we have a stapler, an O-silk on a needle driver, and a Foley catheter ready to plug any hole that we find in the myocardium. In addition to anticipating cardiac injury, we should also anticipate that we're able to repair that injury, and that means that we're going to need to restart the heart. Yes, there are circumstances where you close, you're giving lots of volume, and the heart just starts on its own. But we have to be ready to restart that heart. That means having intracardiac epinephrine ready to go, internal paddles plugged in, knowing the dose that's somewhere between 5 and 20 joules. After we've repaired that injury, while we're doing those things to repair the heart, we do want to provide open cardiac massage. Many people think that this is just squeezing the heart between your hands, but it's really a roller motion. We want to have the base of our palms at the base of the left ventricle, and we're going to be kind of rolling that left ventricle up. That's going to move the blood out of the left ventricle and into circulation. So it is not just an up and down movement of our hands, it's really a rolling forward in order to squeeze that blood out. Finally, remember that when you're doing a left-sided thoracotomy, the right side of the chest is still a black box. That means that at the very least, you need to do a finger thoracostomy on the right side or place a chest tube. If a ton of blood comes out, you're probably going to have to convert that left-sided thoracotomy to a clamshell in order to best identify any right side of the chest injuries. Of course, you can avoid all this by just doing a clamshell on every patient. That's really going to depend on your local protocols or what is locally done. Obviously, there is so much more involved in doing a thoracotomy. This is just one set of tips to improve your skill set. Review this procedure, mentally prepare to do this, watch videos where you can see all of these steps happening. This is the best way to prepare for what is a very uncommon procedure, but one that we really have to be adept at.
Excellent pearls there, Swami. Thank you so much. We've got the best step-by-step thoracotomy video I could find linked in the show notes for you, so please go there to check it out. We're going to shift gears now from the crashing penetrating trauma patient to a more benign topic that I knew very little about before this. And new to EM Cases, it's my pleasure and honor to have the founding editor-in-chief at the fantastic FoamEd website, Don't Forget the Bubbles, a highly recommended resource for just about everything pediatric EM. Dr. Andrew Tagg is an EM doc in Melbourne, Australia, and master educator. He pitched me some fantastic lower acuity pediatric emergencies that we don't often think about. Here's his debut after this short announcement from one of our sponsors. Easy Recess is thrilled to announce that they are now available for institutional access. In addition to providing the app for all employees in your organization, this means access to exclusive features like printable protocols with calculated medication doses, customizable content to fit your local protocols and practices, access to Easy Recess on computers via the web-based version, and much, much more. To learn more, visit the institutional license section at easyrecess.com. And as always, you can download Easy Recess and use the promo code EMCASES, that's EMCASES, one word, to get your 2-month free trial on an individual subscription.
Hi, it's Andy Tagg from Don't Forget the Bubbles. Now, for some bizarre reason, parents and patients love to bring in little gifts as a kind of show and tell for me. I've been brought dirty diapers, worms from both ends of the body, and bugs galore, and I'm usually pretty comfortable dealing with it all. But every now and then they bring in something very different. So just how much do you know about uterine casts? Let me tell you about Lucy, a 15-year-old girl who came into the emergency department utterly distraught. She was in tears, clutching a wad of soggy tissue and terrified of what she had found. She had explained that she thought she was just having a period, but the pain was unlike anything she'd experienced before. And as I delicately unwrapped the tissues, I saw a pink triangle of flesh. It looked like a tiny replica of a uterus. It was, in fact, a decidual or uterine cast. Now, uterine casts are rare, and most people, including many clinicians, have never heard of them. But they've been described in the medical literature for ages. A uterine cast occurs when the entire endometrial lining sheds in one piece. And to a distressed patient, it can look like a tumour or a miscarriage, and it's our job to explain what's really going on. It's like nature made a tiny wax sculpture of the uterus and then decided to return it to sender. Now, let's look at the physiology. Now, the exact cause of uterine casts aren't fully understood, but hormonal changes during the menstrual cycle certainly play a role. Progesterone thickens the endometrial lining, preparing the uterus for a potential pregnancy. If no fertilized egg implants, progesterone levels drop, triggering a period. But sometimes, for reasons we don't really understand, the endometrial lining detaches all at once. And when it does, it hurts. Patients may describe severe cramping or sharp menstrual-like pain. There's often vaginal bleeding, which can range from spotting to heavy flow, and the pain usually comes from the relatively large mass passing through the tiny os of the cervix. The important thing is not to over-investigate. It's not cancer, it's not a miscarriage, it's just a very unusual way for the uterus to press reset. Of course, it's still vital to rule out a pregnancy, particularly an ectopic, so always check a quantitative beta HCG, and if there's been heavy bleeding or a history of menorrhagia, you may want to check a CBC. Otherwise, your job is simple. Reassure the patient in front of you. Offer pain relief when needed. And chalk this up as just another weird day at the office. It's kind of like the kind of thing you'd expect to find in a David Cronenberg film. Part biology, part uncanny. So next time a patient shows you something strange in a tissue, pause, be gentle, and remember, what seems alien to them may just be a very human kind of shedding.
Let's take a little break to hear from one of our sponsors, Metricaid, the experts in complex physician scheduling since 2012. Metricaid's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricaid's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricaid.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES. Uterine casts, who knew? Thanks so much, Dr. Tagg. Last but not least, the brains behind the amazing ECG interpretation courses, the Hearts ECG course, and of course, ECG Cases himself. Dr. Jesse McLaren is going to riff off his excellent recent ECG Cases blog on scale and proportionality in occlusion MI.
You're given two different triage ECGs to sign off, and you notice they both have some ST segment elevation in V2 and V3. Does one, both, or neither of these ECGs represent acute coronary occlusion? For the STEMI paradigm, the answer is easy. Do they meet STEMI criteria, which is defined as ST elevation in the absence of LVH or left bundle branch block? In V2 and V3, the ST elevation has to be 1.5 millimeters for women, 2 millimeters for men older than 40, and 2.5 millimeters for men younger than 40. So for these two triage ECGs, you just measure the ST segment elevation and see if it meets the millimeter criteria based on the age and the sex of the patient. If there's 2 millimeters of ST elevation in V2 and V3, then this is STEMI positive in any female regardless of other ECG features, and STEMI negative in any young male regardless of other ECG features. But if there's either LVH or left bundle branch block, then you cannot apply STEMI criteria. But these criteria, which are not based on angiographic data, are very limited. They can lead to false positives in early repolarization, they can lead to false negatives in subtle LAD occlusion, and they do not help to interpret ST elevation in the presence of LVH or left bundle branch block. All these problems are based on important artistic concepts ignored by the STEMI criteria: scale and proportionality. Scale is the size of one object compared to a different object, while proportionality is the size of one part of an object relative to other parts of the same object. For example, if you find a pair of shoes on the ground, how can you tell if they fit or if they're too big? You can't just measure the shoes in isolation without the person they belong to. You can look at the shoe size, which allows you to measure the scale of this pair of shoes compared to a different pair of shoes, but you can't just declare that all shoes of a certain size are too big. What you really want to know is, do the shoes fit? Are they proportional to the feet they belong to, or are they too big relative to those feet? Similarly, when it comes to acute coronary occlusion, we're not looking for ST elevation in isolation, and dichotomizing the ST segment by millimeter criteria is of limited use. What we're looking for is primary ischemic ST elevation and hyperacute T waves, and we can use scale and proportionality to identify occlusion MI. First of all, we need to leave the ST and T wave analysis until the end of our interpretation, because this is just repolarization, which can only be interpreted relative to depolarization. STEMI criteria train us to look for ST segments in isolation, which ignores scale and proportionality. Instead, using the Hart's approach for ECGs, we look at heart rate and rhythm, electrical conduction, axis, R-wave progression, and tall or small voltages. All of this characterizes depolarization and allows us to assess scale and proportionality. In our shoe analogy, we first need to look at the feet to see if they're wide or narrow, tall or small. This provides a context in which we can interpret the pair of shoes. Similarly, once we've characterized depolarization, we can then assess the pair of ST segment and T waves to see if they fit. If the QRS is abnormally wide from left bundle branch block or ventricular paced rhythm, then we can expect secondary discordant and proportional ST changes. So we can use the modified Starboza criteria to look for superimposed primary ischemic ST changes, including concordant elevation, concordant depression anteriorly, or excessive discordant elevation. The original Starboza criteria defined excessive discordance as 5 millimeters, but that arbitrary cutoff does not consider scale or proportionality. The Smith modified Starboza criteria defines excessive ST elevation using proportionality as greater than 25% of the preceding S wave. So 7 millimeters of ST elevation could be proportional to very large voltages of one ECG, while only 3 millimeters could be disproportionate elevation to very small voltages of another ECG. If the QRS is abnormally tall from LVH, then we can also expect secondary discordant and proportional ST changes. While there's no evidence-based criteria to identify occlusion MI in the presence of LVH, the concepts of scale and proportionality can help to identify disproportionate superimposed primary ischemic ST elevation. If the QRS is normal, then we can look directly for primary ischemic ST elevation and hyperacute T waves. the two triage ECGs might have the same amount of ST elevation and the same amplitude of T waves. But if the scale of the QRS is taller in the first and smaller in the second, then the ST and Ts in the first might just be proportional and fit the pattern of early repolarization, while the STs and Ts might be disproportionate and ischemic in the second. To finish off the shoe analogy, if the ST segment and T waves represent a pair of shoes, just remember that both shoes need to fit, and it's not much use having one proportional shoe and one disproportional shoe. Similarly, occlusion MI can present with hyperacute T waves in the absence of any significant ST elevation, where the ST segment might be proportionate, but it's the T wave which is excessive, ischemic, and disproportionate. Hyperacute T waves are still in the process of being defined by the emerging occlusion MI paradigm, but central to their definition is proportionality. What defines a hyperacute T wave is not its amplitude in isolation, but its size relative to its QRS. Hyperacute T waves look inflated, wide-based, bulky, and disproportionate to their QRS.
All right, hope you learned a little something about whole blood transfusions, resuscitative thoracotomy, using calcium to prevent hypotension, in rate control of rapid atrial fibrillation with diltiazem, dynamic left ventricular outflow tract obstruction, or LVOTO, and scale and proportionality in MI. May 23rd is your last chance to get access to all 26 EM Cases Summit talks and the ebook summarizing all of those talks through emcasessummit.com. It's a great opportunity to collect CME points on your own time. Thanks for listening, and thanks for your ongoing support. Until next time, take it easy.
Baby, you to wipe the tears from my eyes.